So, opioid pharmacology, for this part, what Abhirami has presented is an excellent preparation. You can make it a little more concise because in the theory exam, you will not have time to write all those details. So, you can make it a little more concise. And
Yes, sir.
this presentation, what I have made is going to give you some recent advances and inputs on opioid receptors. Okay, they are a group of analgesic agents commonly used in clinical practice. This all of you know because every day you are using fentanyl or pethidine or sometimes morphine also. So they are the commonly used analgesic agents, and even the tramadol that you are using routinely nowadays is a weak opioid only. So all these drugs are commonly used. So there are three classical opioid receptors: DOP, KOP, and MOP. They are not called anymore just mu, kappa, and delta. It is called opioid peptide. So it has to be called like this only. And there is a new normal nociceptive opioid, which is called NOP, the branch of opioid receptor family. And all of these act as the receptors like agonists, antagonists, or partial agonists. And also there is another term which is called inverse agonist. And they bind to the G protein coupled receptors called cellular and cause cellular hyperpolarization. So this picture, many of you may be aware of the mode of action of the G receptor. So when a ligand comes and binds into that is called the agonist, and the signal is given here. The G protein is a heterotrimeric protein. This is the G protein, what we call as. It is a heterotrimeric protein. That is, three components are there: alpha, gamma, and beta. Okay? Of that, the alpha and beta, I mean gamma and beta are always clubbed together, and alpha is a separate unit. So once the stimulus comes here from the exterior, so this is the cell membrane, and the signal is have to travel through 7 parts. That's why it's called uh, 7 channel or a 7 serpentine receptor, because it bends like this and comes inside. Once the stimulus comes inside, what happens is the GDP which is there will be phosphorylated to triphosphate, GTP. And once the GDP gets converted to GTP, this trimeric protein, that is the three proteins which are combined together, is broken down into this alpha unit separately and the beta and gamma unit separately. So this broken alpha unit will go and stimulate, inhibit the calcium channel, which is a voltage gated channel, and prevent the extracellular calcium coming into the inside of the cell membrane, the neuronal membrane for that matter. And also it will activate the potassium and channel and cause elimination of potassium, which will result in the so-called hyperpolarization or increased negativity of the inside of the cell, and also acts on the adenyl cyclase enzyme and causes the inhibition of cyclic AMP. So all these things are the main modes of action of this G protein. And the most opioid analgesic bind to this mu receptor and MOP receptor. That is the major analgesic component of the opioid receptors. And they can be classified as based on their availability, whether they are naturally occurring, semi-synthetic, or synthetic. And these are all the examples of that. The common naturally occurring example is morphine, which is derived from Papaver somniferum, which is a alkaloid plant from which it is extracted. And you have this codeine and thebaine, papaverine, which are also the naturally occurring opioids, but these two, the thebaine and papaverine, have more actions on the vasculature rather than on the analgesic component of that. And these are all the semi-synthetic, and of that buprenorphine, oxycodone are commonly used in clinical practice. And all the other things, pethidine, fentanyl, alfentanil, remifentanil, which we are all used to, they are all synthetic drugs, which are purely chemical, which are synthesized in the laboratory. And This picture is a little different from the earlier picture with what I showed. This also shows how the G protein coupled receptors are activating. But the modern concept is there are two signaling pathways. This signaling pathway is mainly for analgesic component, where it activates the GDP to GTP and breaks down the primary G protein into alpha and beta gamma subunits, and they cause calcium channel inhibition and potassium channel activation, and also act on the adrenal cycle. What is not commonly given in all the other books is the modulation that is being done by the same channel by activating some other mechanism, what is called the beta arrestin stimulation, which acts on the mitogen activated protein kinase and acts on a slightly different way to counteract this. You will see the importance of this particular half later. So following agonist binding, this is what I described as the signaling pathway, and this inhibits the inactivation of calcium and activation of potassium channel. And the predominant right side, what I showed you, this side, right side, is the beta arrestin signaling pathway, where the G protein receptor kinase phosphorylate activate the receptors to enable the beta arrestin, leading to the internalization and desensitization of opioid receptors and activation of this mitogen associated protein kinases. So this will lead to proliferation, differentiation, and apoptosis. So these are the two components of the stimulation. So because we are more interested in analgesia, most of the books will stop the description as I showed in the earlier picture up to this. But this right-hand side is also equally important, and that is where the term biased agonism has been introduced. So in biased agonism, which is called functional selectivity, there is an ability of particular ligand to drive one signaling pathway over the other. So what you have to understand is when the ligand binds to the G protein coupled receptor or the 7 channel or serpentine receptor on the exterior, it not only stimulates this half of analgesia producing component, it also stimulates this half, the second half. Okay, and some drugs preferably stimulate. For example, if you give morphine or fentanyl or other major MOP preferable drugs, they will stimulate majority the analgesia component. So patient will experience very good pain relief. On the contrary, some drugs have a majority effect on the right hand side, beta arrestin stimulation, which may result in the other effect, and that is what is called the biased agonism. Whether it is purely or majority stimulates the analgesia component, or the non-analgesia component is what is called the biased agonism, which is a new term which is introduced recently. And the importance of that is you can have always, this picture tells you the ligand classification and the two types of G protein conformation. One is A for analgesia, is B for beta arrestin. So if a drug may have equal effect on both these things, then it will have both analgesia as well as the side effects of the opioids. It may be predominantly analgesia stimulating. Then it becomes biased towards the analgesic component, which will produce more analgesia and less side effects. The third group of drug is more predominantly stimulating the arrestin, so more side effects and less analgesia. So this explains nicely the mode of action of some of the common drugs which are used now, and that is a newer thing that is happening. Another important recent advances in this particular opioid receptor pharmacology is the allosteric modulators. Have you heard this term, Virami? What is this allosteric modulator? These are all little more advanced.
Find a different site.
So there are two types of sites for attachment of the ligand. One is called the orthosteric site, okay, and another is called the allosteric site. I'll show you a picture where it will be easily understandable. Now, this is the picture of the seven parts or seventh channel G protein ligand in the cell membrane. Okay. Now, this blue is a orthosteric ligand. It will come and attach to that. This blue triangle, what is there. Now, once the ligand comes and gets attached here, it produces a response. Okay. This can be a single ligand, which is called a univalent ligand, which causes the stimulation. Or it can be a bivalent ligand, where it can be two ligands which come and get attached to the adjacent two sides of the G protein. And this can be like this, either a brown triangle or a blue triangle. Okay, and they also produce the same response. And the third is the biased agonism, what I showed you. When comes a ligand which has got a more of a analgesia component, you can see the response one is more towards analgesia and response two is towards the side effect stimulation, which is much less. And another type of modulator is the allosteric modulator, which is present in between the channels, not on the surface like this. And they also have some effect in modulating the negative or positive effect and the neutral effect. So this is the more recent biochemical analysis of the action of the opioid receptors, but the ligands which are univalent, bivalent, it can be selective with the bioorganism, and it can be modulated by the allosteric and the orthosteric receptor sites. So this is this NOP receptor, which is also having a precursor called OF2, alpha quinine, which is important in sepsis and immune vascular axis. So in sepsis, what happens? You see this picture, a normal person having a normal vessel, he is having a normal endothelium, blue color endothelium. And when the endothelial nociceptive receptor binds here, what happens is it activates the mitogen accepted protein kinase activation with the G protein receptor activation. And you can see there is a vasodilatation, because these ligands come and activate the G protein on the endothelium, and this lipopolysaccharide and peptidoglycan linings are affected. And you can see the vascular tone, which is normal here with a small vessel, goes into fully dilated vessel. And that is the reason why we have been always now trying to constrict these vessels with noradrenaline as the ligand of choice for increasing the BP and improving the perfusion. Now, all of you know that the drug of choice for sepsis hypotension is noradrenaline infusion. But the new theory that they have found out is this is the activation. So if you block this nociceptive opioid, your dosage or requirement of noradrenaline will become much less, and the improvement in the patient's condition is much, much better compared to giving noradrenaline alone. And you can see the blood pressure, which was normal, and the organ perfusion, which is normal, completely goes down. And the vascular tone lost, and patients become vasodilated. So this picture beautifully describes the importance of this nociceptive opioid receptor, which is a important finding in the sepsis and immune vascular axis. So instead of dealing with the routine pharmacology, I thought these two important messages will be useful, because this is going to be the description in future compared to the old description. Now, coming to the opioids, they can also be classified according to their effects on the opioid receptors as agonists, partial agonists, and antagonists. And they interact with the receptor to produce maximal response. And receptors produce no functional response and preventing an antagonist like naloxone when it binds, that also binds to the same G protein complex receptor, but it does not produce the normal analgesia and other things like your opioids. On the contrary, it is able to reverse the effect of the opioid, and so it is called the agonist, whereas a partial functional response is produced by a partial agonist, where it will produce the analgesia component. But what is the difference between the morphine and buprenorphine? When you call them as agonist and partial agonist?
It is a kappa antagonist.
No. What is the major difference
only
between
binds.
morphine and buprenorphine, which are called agonist and partial agonist? Morphine, when you give more and more drug, what will happen? Will the analgesia become more intense or less intense?
Less intense.
Less intense. Then why do you keep on giving high doses for palliative pain, cancer pain?
In buprenorphine is partial agonist, sir, then
it will not increase the analgesia.
Yes, sir.
The partial agonists, they have what is called the ceiling effect.
Yes.
After a particular dose, however much you increase the dose, it will not increase the quality of analgesia, rather it will produce only the depression. Okay? Whereas morphine, by increasing the dose, you can increase the intensity of analgesia also. That is the major difference between morphine and buprenorphine. And type of opioids and their endogenous ligands, because endogenously also we have some drugs or chemicals which can stimulate the opioid receptors, and that knowledge is very, very important because there are precursors for DOP, that is denta-opioid peptides are proencaphalin, which get the active form is metencaphalin and leuencaphalin. Similarly, for MOP, you have beta endorphin, endomorphin 1 and endomorphin 2. Now, there is a research going on in finding out why the tolerance to pain differs from patient to patient. For example, if a person in the village, he gets hurt with a big stone, or a tree trunk or a branch falls, or he gets a cut when he is pruning a tree, he will just apply some local mud or squeeze a bit of natural leaves and apply it and just walk it away. His pain tolerance is so good that he will not make a fuss about it. On the contrary, you would have seen a city-bred patient when they come for anesthesia. When you want to give a IV line, this patient will shout, "Doctor, please take no. Please make it less painful," like that. They make a lot of fuss, isn't it? All of you would have seen patients doing like that. Whereas a patient coming from a urban area, he will be very calm and quiet, and he will cooperate well for starting an IV line. This difference is mainly because of the endogenous ligands, which are able to stimulate the opioid receptors and make them tolerate the pain much better. So this is a very important part of this. So stimulation of these opioid receptors, they produce all these various effects which she nicely described. So I don't want to waste time on that. And KOP receptor stimulation is very important because they produce final analgesia, diuresis, and dysphoria. So coming to and NOP also has to be included, so produce partially some analgesic effect, and they are responsible for hyperalgesia and allodynia. So now you have a question in your theory, opioid-induced hyperalgesia. That is a question that is frequently asked, and they have found out that component is because of this. And that is where I told you the two responses of stimulating the opioid receptor, one on the analgesia component, the other on the beta-arrestin component, which only produces all these problems. So this NOP also has to be included in your answer. That is the message that I want to tell you. And how is the analgesia mediated by that? Will this attachment just simply produce all that? Because the opioid receptors are distributed in three places. One is it is present in the central nervous system. It is present in the peripheral nervous system, and they are present in non-neural origin also. So their locations are in three different places. They are ubiquitously present, and that is where your endogenous ligands are able to stimulate them and produce and differentiate the quality of or the tolerance level of pain, or the threshold for pain is different from person to person because of the distribution of these opioid receptors at these three levels and their endogenous stimulation. And centrally, high concentrations of opioids are present in the periaqueductal gray area, rostral ventral medulla, and substantia gellosa of the dorsal horn. And these are the four areas where they are present. And the activation of this MOP receptors in the midbrain is thought to be the major mechanism for producing the analgesia component. And MOP acts by stimulating the inhibitory pathways, which act on the periaqueductal gray and nucleus reticularis and paragigantocellularis nucleus. And the net effect on activation is a descending inhibitory neurons which are activated. So there is an inhibition of the pain transmission from the periphery to the central cortex. That is the main mechanism. So this leads to greater neuronal traffic through the nucleus raphe, increasing stimulation of dihydroxytryptamine enkephalin containing neurons and connect directly with the substantia gelatinosa. And this causes a reduction in nociceptive transmission from periphery to the thalamus. So you have to block the pain origin. For example, if you do a laparotomy, the pain is originating in the anterior abdominal wall. So that has to be carried to the spinal cord. From the spinal cord, it has to traverse upway through the pain pathway to the thalamus, and then from the thalamus to the sensory cortex of the brain. So that is the whole brain pathway or pain pathway all of you would have studied. So you have to block that transmission. If the afferent sensation is not reaching the central cortex, then the patient may not feel the pain. So that is the mode, or it should inhibit the transmission from above. Either it should block it from the periphery towards the thalamus, or it should inhibit from above downwards. So both are taking place in the management of opioid receptors. And this picture, so the exogenous and endogenous opioids exert a direct inhibitory effect upon the substantia gelatinosa and also peripheral nociceptor afferent neurons, reducing the transmission. So two important components. One is blocking the conduction of pain sensation from periphery to the central cortex and inhibiting the transmission from above by the inhibitory pathways. If you remember the simple way, these are the two mechanisms by which the opioids act. And you can see this picture tells you where all they are acting. So by acting between the cortex and the periaqueductal gray, it can cause the activate the inhibitory pathways, and inhibitory pathways block the dorsal horn from where it has to go. And from the periphery, when it goes to the dorsal horn, opioids also act here. And the third location, they act in the NRPG, which is the nucleus reticularis paragigantocellularis. So these are the three locations where the opioids act. And the two mechanisms is, one is inhibition from above, two is blocking the sensation afferent from the periphery to the center. So if you remember that way, it is easy to remember this mechanism. So the pharmacology and pharmacodynamics, they can be administered by so many routes. That is, the morphine especially can be administered by oral. Oral is mainly for which type of patients who are given morphine tablets?
Cancer patients.
Cancer, palliative care, terminal cancer patients, they take, what is the maximum oral dose of morphine? Any idea about palliative care? They give up to 80 milligrams in divided doses. Okay, so maximum dose in palliative care in intractable cancer pain is up to 80 milligrams. Even though the side effects are quite severe, but the patient is happy because the pain is very relieved by that. So oral route, intravenous, subcutaneous, transdermal. We nowadays use buprenorphine patches fentanyl patches, all of you must be aware of. So the route of administration is very, very important. And sublingual, very quick action, avoids the first pass metabolism. So the drug availability is very much high, and epidural, intrathecal, and intra-articular routes are also being given. And what is the specific thing that you have to be careful when you administer morphine by epidural or intrathecal route?
Lipid solubility, low lipid solubility.
Delayed
What is
respiratory
the
depression.
precaution? What is the precaution to be exercised in the drug?
Delayed respiratory depression.
No. You are talking about the effect of the drug. I am asking about the precaution to be taken. What type of morphine you have to use? You use it in the
Preservative
epidural.
free.
Preservative free, very, very important. Okay, what morphine or that is the reason why buprenorphine and fentanyl are easily administered, because both are preservative free. Okay, whereas if you take your morphine ampule tomorrow, you go and see, it will have a preservative in the form of metabisulfite or a methyl paraben. Okay?
Yes, sir.
So the preservative free is very, very important. Otherwise, it will be neurotoxic and it will cause severe neuritis problem, or chemical neuritis will happen. So any drug morphine which is given epidurally or intrathecally should be preservative free. That is a very, very important caution that has to be exercised. And the morphine, as it is, has very low lipid solubility. It is more of a water soluble drug. So it penetrates the blood-brain barrier very slowly, and that is why morphine, when administered intrathecally, may cause respiratory depression as late as 18 to 24 hours. So you cannot just administer morphine. What is the intrathecal dose of morphine?
0.1 mg. 100 mics,
Intrathecal, 50 to
300
Total,
mics.
300 mics.
maximum, how much you can give?
300
50
mics.
to 300 mics.
3 milligrams. 300, not 300 micrograms. This is a maximum you can use is 3 milligram intrathecally, and epidurally you can go up to
3 to 5 mg.
5 to 8 milligrams. Okay, and it is metabolized into by the liver in glucuronidation, and the active metabolite is excreted in the urine, and this metabolic component, morphine 6 glucuronide, is it active or inactive?
Morphine active.
Active.
Equally active. So metabolite of morphine 6 glucuronide has a longer duration and more potent than the parent compound. So that is the reason why, even though the drug is metabolized faster, the product of metabolism is also equally effective. Okay? And elimination half-life is around 150 minutes, that is 2.5 hours, and it is altered by age, concomitant use of other medications, and the derangement of renal or hepatic function. So when you use it, it is contraindicated actually for renal transplant patients, because the 6th morphine glucuronide will be acting for a long time, because it is not eliminated by the kidney, and they don't advocate usage of morphine for renal transplant recipients actually. And the side effects can be classified as transient side effects, which cause nausea, vomiting, and pruritus, and persistent side effects in the form of constipation and hypogonadism. And tolerance and dependence in opioid therapy. Tolerance, what is tolerance actually? How do you define tolerance?
Physiological adaptation to chronic opioid exposure.
So what will happen?
Decreased effect of the drug.
We have to keep on increasing the dosage of the drug. Okay, that is tolerance. For example, a patient who had a good pain relief after a major post-abdominal surgery, first day you give him 10 milligrams of morphine, he is very comfortable. Second day, you give 10 milligrams, he says still there is some pain. So you have to increase it to 15 milligrams. Third day, again he says still there is some pain, you have to increase it to 20 milligrams to achieve the effect that you had on the first day. So like that, gradually patient will require more dosage to get the same amount of analgesia as what he had with the lesser dose on the first day. So that is called tolerance. Okay? So tolerance is the condition in which patient requires a larger dose of opioid to maintain the same level of analgesic relief. What is dependence?
Addictions.
Addiction and dependence are
Increases in pain.
similarly, but what will be the nature of patient when he becomes dependent on opioid? He will have violent withdrawal syndromes. Okay, if the dose is not given, he will have violent, unpleasant, distressing withdrawal symptoms on abrupt discontinuation. That is called dependence. And addiction is patient will be craving for the drug. He will say whether he has pain or not, he will say, doctor, please give me that injection, what you gave me yesterday. That amount of craving will be there. Whereas in a dependence patient, you have been giving morphine for 3 days. Fourth day, you have not administered the drug at the particular time. Patient will not be asking you for the drug, but he will have severe violent disturbances of nausea, retching, complaining of excessive pain, but he will still not be asking for the drug. So, but here he has become dependent on the drug. So the violent withdrawal reactions is called dependent, whereas the craving and the patient asking you for the injection is addiction. Okay, so that is a simple difference between dependence and addiction. And the uses of the drug in anesthesia practice, it is used for providing anesthesia totally and supplemental sedation during procedures requiring general anesthesia or monitored anesthesia care. It is utilized for post-op pain control, utilized intrathecally and epidurally to provide targeted pain relief. What is the advantage of parenteral or oral to intrathecal and epidural morphine or opioids?
Side effects.
Side effects or dosage?
Dose is
The
less.
dosage
Dosage,
required
less
is
dose.
much less compared to the parenteral route. And the
Exactly.
second thing is the onset of analgesia is much more faster compared to the parenteral route. So, and it is more target relief pain. That is, if you give it in the thoracic or in the lumbar region, the abdominal surgery patient will have immediate pain relief. Whereas it will take some time, administered IV or sublingual or oral, whatever route. So the onset is much faster. And final opioids offer super analgesia compared to intravenous and have a similar side effect profile like pruritus and being the most common problem with that. And opioids can be used as a primary anesthetic agent in major cardiovascular surgery. In fact, the open heart surgical procedures which are done under cardiopulmonary bypass, there are two techniques of induction. One is opioid-based anesthesia, the other is volatile-based anesthesia. So in opioid-based, you give fentanyl at the starting dose of 10 to 15 micrograms per kg body weight, not the 1 to 2 microgram what you give as a minuscule dose for your regular surgeries. You can use up to 15 to 20 micrograms also per kg body weight as a first induction dose in major cardiac surgeries. And that is where you get the muscle rigidity and the respiratory breath holding and all those things. Chest wall rigidity is the most common side effect of such massive doses of fentanyl when it's given as a part of opioid-based anesthesia technique. And they are used for managing chronic post-surgical pain as well as palliative care for pain relief in terminally ill cancer patients. And opioids are administered for labor anesthesia, either by intramuscular route. Pethidine is the common drug given for managing the labor pain during the first stage of labor, and also it can be given as an IV infusion and also as a neuraxial route. And they are used in trauma, burns in acute settings to help restore the hemodynamic instability by relieving the pain also. Okay? So these are the points. I have not purposely made the answer routine like a pharmacology question, what Abhirami has prepared. You can make your answer more concise and include the recent advances and the other recent things which have happened in the ligand binding to the G protein complex. And the mention of the NOP, nociceptive opioid receptor, also should be included in the answer. So that the answer is not complete. Okay.
Yes, yes, sir.
Right.
Thank you.